So the second step after taking into consideration about geriatric population and how they are different, how their physiology is going to different, how their pharmacology is going to be makes difference, and what are the physiological manifestations that you may find in geriatric population. The second step is about geriatric assessments. So geriatric assessment is very crucial, that you need to assess and do some assessments in terms of geriatric population. So we'll see that. Why why we need to assess this? What is the objective of the assessment? What are the kinds of assessments and what are the tools of the assessment? This is what we're going to cover in this presentation. So why to assess? Because of the complexity of the presentation, maybe they're not a straightforward case. They as we discussed that patients who has suddenly developed irritability, decreased appetite, we may ended up diagnosing him as UTI or pneumonia, although he or she doesn't have any problem with the urinary symptoms. He does not have any symptoms regarding cough, but he may have pneumonia, because this is complex thing. They have unique mode of presentations, multiple illnesses together, elderlies, marginal reserves, prevention and maintenance. This is what we have discussed. So, all right. All right, Ismail Makhzoom, can you read the case?
Yes, doctor.
Yes, please.
A 72-year-old female with hypertension admitted for urosepsis with fever, weakness, and a positive urine culture, placed on IV AMB and Gent Q8 hour.
Okay. So this is IV ampule, ampicillin, and gentamicin Q8 hours.
Oh, ampicillin and gentamicin for 8 hours.
Yeah.
Assessment included vitals, auscultation of heart, lungs, and abdomen exam. Lab included CBC, chest X-ray, urodynamic.
Yes. Just let me see here.
Sorry, doctor, but I don't know what DR stands for. And lytis, CR and
okay. So included CBC, chest X-ray, urine DR, and electrolytes, creatinine, and random blood sugar.
on day 4, patient become confused, combative, and fails despite absence of fever. Continues to stay confused on day 7 despite normal CT scan and corrected sodium. Discharged to nursing home on day 11. What problems and assessment can you identify?
Okay. So, all right. So, Tasneem, what are the issues that are there? Yes, Tasneem, can you hear us?
Yes, doctor. I will read.
All right. Okay. So what are the issues that you think that the patient has?
He might have UTI.
No. First, we will see what are the problem that is there. Yani what is the issue? This is the diagnosis. UTI. This may go into UTI. Yes. All right. So what is the problem here?
First, he's suffering from shock.
Shock. Okay.
Yeah, and he already have predisposing factor like hypertension.
Yes. Okay. So yes, urosepsis with fever and weakness, and then what happens? He becomes more confused, and um, falls and absence of fever, although there is absence of fever, but this his condition is going to is getting worse, right?
Yes.
Okay, all right. So let's see. Okay. So the objective is to, there are a lot of issues that are there, and how are we going to address all these issues in this presentation, we will learn that. So gathering information about the functional, psychological, neurological, social, nutritional status along with the presenting complaint. Identify the patients at risk for complications, prevent these complications, and so that you can improve the outcomes. So this should be our objectives. So let's discuss about geriatric population, what different tools, maybe you can say for different systems. We are aware of cardiovascular system, respiratory system, musculoskeletal system, but there is some different identities and tools that we use it for a geriatric population in order to assess the different components. For example, here, if you see here, there is functional component. So the patient is functional or not. Functional or not means that the patient is dependent or is independent. This is, you can assess by two things, which is called ADLs and IADLs. So ADLs are activity of daily living. The patient is able to do normal work at home, that he's able to drink on its own, he's able to go to the bathroom on its own, he's able to take shower on its own, and he changes clothes on its own. So all inside activity he's able to do it. If he's able to do all inside of activity, that means he's independent inside. So this is called activity of daily living. So you ask within the history taking, apart from presenting complaint and history of presenting complaint, you will assess the functional component. And how are you going to assess the functional component? By asking ADLs. All right. Second thing is IADLs. This is outside activity of daily living. Any activity of daily living which is outside is called IADLs. That means going to the bank. In our scenarios, the patient going to the mosques, coming back, going for the groceries and going for shoppings, so doing driving. So any outdoor activity, this is called IADLs. So functional component has two domains. One is inside the house and the other is outside the house. So this is how these are two questions is going to give you an answer about the functional component, whether the patient is independent or not. So the second component is neurological. In neurological, you need to, you are also done with psychiatry, right?
Yes.
Yes.
Yeah.
Yes,
So
doctor.
in this, what you're going to do is you know that you have MMSE. MMSE is a detailed neurological assessment. But here, what we do in family physician is we do mini cog. Mini cog is a very minimal cognitive function test, and how you're going to perform it, we'll learn later on. The third component is a nutritional component. So if the patient is, whether the patient is taking normal nutrition or not, or is it malnourished, and so on and so forth, this is also going to be very important. The appetite, weight changes, teeth problems. So this is going to contribute on the nutritional status. That's also very important. The other component is get up and go test. This is for you can say to assess the risk of fall. So you perform this test and then you will identify those patients who are at risk of developing fall. The other thing is psychological geriatric depression scale. So you also would like to assess those patients with depression, and you also would like to assess the support system and living arrangements and autonomies to the patient. So you need to know about geriatrics. So you see here, we did not discuss about different like we do it in a normal component like CVS, cardiovascular, and these examinations. So we have some different perspective of assessing a geriatric population. So these are the tools that are there. ADLs include, as we discussed, feeding, toileting, showering, transferring, dressing, and IADLs are grocery, use of telephones, any outdoor activities. Neurological assessment is through MMSC. We are not going to discuss MMSC. What we are here concerned about the mini cog. How are we going to perform a mini cog? We are assessing the neurology now. We are assessing the neurological components. So it is just the 4-step procedure. Step number 1, remember and repeat 3 unrelated words. So in first step, you ask the patient to remember 3 unrelated words. You give the patient 3 unrelated words like pen, fan, and door. So these are all 3 unrelated words that doesn't have any relationship with each other. So you ask the patient to please remember these 3 words. This is step 1. Step 2 is you ask the patient to draw the clock. So this is actually a distractor. So you asking the patient to draw a clock. Drawing a clock is like this. So you ask the patient to make a circle, and then you ask the patient to please kindly draw it 9 o'clock or 3 o'clock or 4 o'clock. So the patient is going to draw picture, something like that. So when he draws this clock, then the third step is going to be repeat the previously presented words. So you ask them to recall these 3 words. And step 4 is your interpretation. So if the patient doesn't remember, and you give 1 point to each, like if the patient has recalled all the 3 words, it's going to give 2 points, and then clock draw test is going to give 2 points. So if the patient does not able to remember all the 3 words and is not able to draw a clock, it is positive for dementia. So you would like to refer this patient for further evaluation from the psychiatrist, or you want to assess the correctable causes for dementia, maybe some infections going on, so on and so forth. So this patient is positive for dementia for sure. If the score is 1 or 2 with abnormal clock draw test, so you give Yani, there is how are you going to score this? You're going to score with each word he remembers, you give 1 score. So if the patient remembers 3 words, you're going to give 3 score, and then you assess the clock draw test. So the problem lies here. If the patient remembers all the 3 words after drawing the clock, it is negative for dementia. This is a clear-cut picture. The second scenario is about 0 score. A patient does not remember anything from the previous words, so that is also positive for dementia. But the problem lies is if the patient remembers 1 or 2 words, not 3 words and not 0. So if the patient remembers 1 to 2 words, then you are going to assess the clock draw test. Whether this clock draw test is abnormal or not is going to decide whether the patient is positive for dementia or not. So with 1 or 2 words, he also has abnormal clock draw test, it's going to be positive dementia. With 1 or 2 scores same, but the clock draw test is normal. So if the patient has normal clock draw test, this is going to be negative screening for dementia. Okay, so mini-cog is clear now. So you have a 3-step recall. 1 step is giving 3 words. 2 step is ask the patient to draw the clock. And 3rd step is to repeat these 3 words. Once all these 3 words are there, then you're going to say that that this is positive for dementia or not positive for dementia. Okay. Uh, as far as the assessments are concerned, so we need to assess the vision, the hearing, which may be responsible for falls, depression, and deliriums. So for the nutritional thing, you also need to ask, is the patient at nutritional risk due to some diseases or disabilities? Is the patient is at risk of disease or disability because of poor nutritional status? So proper history, including dentition, appetite, bowel habits, mobility. These are all important in assessing for nutritional component. You also need to do some anthropometric measures, which can give you an idea whether the patient has nutritionally stable or not. Now, what we will going to discuss is the get up and go test. So get up and go test is going to assess the risk of developing fall. Get up and go test is what? Is a quantitative evaluation. You ask the patient to walk 10 feet. This is the functional mobility, and you time that. You ask the patient to to stand up from the sitting position. Okay, so you ask the patient to, so get up and go test is a timely performed activity. The patient, for example, the patient is sitting in the couch or the chair. You ask the patient to get up and 10 and walk 10 feet. That means 10 steps. Patient walk 10 steps in the straight line. Ask the patient to return back and 10 steps backward and again sit on the chair. So this is the whole command that you're going to give to the patient. And then you time this patient. So what is the normal? If the patient completes all its activity up till 10 seconds minimum, this is good, acceptable. But some patients are a bit slow, generally slow, not for the disease causes. They are generally a little slow. They take time. Up to 20 seconds, this is all acceptable. So you ask the patient to get up, walk 10 feet, to turn around, come back, sitting in the chair again. If it is within 20 seconds in the upper limit, this is all acceptable. But if you see that the patient is taking more time, if the patient is very unstable while walking, and these are all is going to point towards that the patient is at increased risk of fall, and then you need to identify the risk factors within those patients who are at risk of fall. So the purpose here for the assessment is to screen those patients who did not explicitly express their problems. So we need to identify the issue and deal it before it happens in order to improve the quality of life of a geriatric population. So get up and go test is clear.
Oh,
Yes,
yes,
doctor.
very clear.
Okay. All right. Now we're going to ask about depression. So in depression, you need to ask just two quick questions. In the past 2 weeks, if the patient has little interest or pleasure in doing things, number one. And second thing is if the patient is depressed or hopeless in the last 2 weeks. If the answer is yes to all those two questions, the patient may be at risk of developing depression. So you may want to seek help from the psychiatrist, or you may want to counsel the patient. You may want to address some social support, some any other factors that are there for these patients. To address the possibility of developing depression. So remember, these are all screening tools. These are not diagnostic tools. So that can give you an alarm that okay, this patient may go into depression, this patient may go into fall, this patient may have some functional impairment. So these kind of things, this is what you're here for. As a primary healthcare physician, you need to screen for different problems and act proactively. Obviously, some social arrangements are also very important. What is the support system? Does he live alone? Is living with his son? Or what is his daily routine? So all kind of social things are also very important in geriatrics. So this was the same case. So there are a lot of problems in this patients. So as far as the geriatric assessment is concerned, what we are here to as a take home message, that you need to assess those population in these terms, and you should know what are the tools attached to it. So functionally is very important, neurological is very important, nutritional aspect is very important, get up and go test is very important, assessing for depression is very important, and social support, to explore about social support, is also very important. So what I would like you to do is, when you go into your primary healthcare center, try to apply these tools. You don't have to apply all the tools on just one geriatric population, because you because there are a lot of patients, and the patients not going to give you much time. So maybe when one geriatric population which is here for a medication refill, you may want to assess for his functionality. So this is how you're going to assess for different modalities.